Discoid meniscus is an altered morphology that could be present in around 2% of population. The meniscus, usually the lateral meniscus, instead of becoming a C-shaped structures, stays like a disc, occupying the entire lateral compartment. Many people with discoid could be without symptoms. Some could be having mechanical symptoms without a tear, like locking, thud-like sensations and catching. When a tear develops, they develop pain along with mechanical symptoms. 3 types of discoid meniscus have been described. Type I being complete. Type 2 incomplete, and a Type 3 which lacks a posterior tibial attachment and is virtually floating except for a ligament of Risberg. The tissue of the discoid meniscus could be poor in quality due to altered collagen, and the meniscus can have increased mobility due to poor soft tissue attachments. Characteristic findings like flattening of lateral femoral condyle, joint space widening and cupping of lateral tibia are described. But X-rays are hardly diagnostic. MRI is very valuable. In the coronal section, a thick meniscus which is more than 15 mm or a meniscus that occupies more than 20% of the width of the tibia is suggestive of a discoid lateral meniscus. In a sagittal section, if the bow tie sign can be seen in 3 or more cuts, it once again suggests discoid meniscus. Saucerisation, in which the central portion along with the tear is trimmed to give the discoid meniscus a proper shape. If there is a peripheral laxity, a suture repair is also advisable. In this case we present a video of 23-year female, who presented with pain and catching the lateral compartment, shows a complete discoid meniscus which is occupying the entire lateral compartment, and a tear can be identified near the posterior third. A hook radiofrequency probe is used to mark and cut the central portion. The hook is valuable and it makes the anterior work simple. The radiofrequency hook is valuable and it makes the anterior work simple. Here a radiofrequency probe is used to mark and make the anterior cut. The probe is used to carry out the posterior cut, including the tear in the process. The central portion is cut with punches and removed with a shaver. Further shaping of the anterior horn is done and debridement done. A meniscus is punches used from the anteromedial portal. One could see the difficult approach, and hence special meniscus punches like rotary and reverse cutting punches will be useful in this situation. A far medial portal can also be HEP. On palpation, the meniscus body exhibits increased mobility and horizontal tears. The tissue quality is also appears poor. Hence an all-inside repair is carried out. A fast-fix meniscus system is used. The needles are delivering implants above and below the meniscus, in a vertical fashion. As the knot is tightened, we can observe the fixation of meniscus. And further trimming is carried out and posterior attachment was confirmed. Further smoothening of the frayed meniscal edges are done with a radiofrequency device. Discoid meniscus tears could be rare. One may require special instruments like backbiting meniscus punches and rotatory meniscus punches to deal with the anterior third. A far medial portal can also be helpful to address these lesions. We hope the video was helpful to you. Thanks for watching.